It opens or closes.
opens and closes the valve, and فكرت it closes permanently أو it opens permanently. Huh?
For example, prevents blood from moving back to the ventricle to the aorta.
Okay. Yeah.
Because blood flows from higher pressure to lower pressure. So when ventricle contracts, there's higher pressure in ventricle than in the exit. So
This is your problem when you answer SAQs. إحنا people who mark, we don't read. We just want simple answer, 2 words. We look for keywords and then we'll give you the mark. Don't try too much with the SAQs. يعني my advice, لأنه if you want to mark for 400 people and I don't know how many questions you're not going to read, newspapers, it takes too much time. But try to be up to the point and as simple as you can. That's my advice to you. It's simply preventing the blood from going back to where it came from. That was coming from the atria going to the ventricle. When the ventricle contracts, what will prevent the blood from going back to the atrium? A valve. Then the ventricles contract and the blood through the aorta and the pulmonary trunk. What's going to prevent the blood from going back to the ventricle? The valve. So we have 2 types of valves. Valves between the atria and the ventricles, we call them the atrioventricular valves. And then we have valves at the beginning of the 2 major arteries, the pulmonary trunk and the aorta. How are they different from each other? Yes, in terms of structure and in terms of function. So if we open any of these valves, the atrioventricular valves to start with, they're going to look something like this. It has leaves or cusps. On the right 3, on the left 2. So tricuspid or bicuspid. And we have these muscles in the ventricles. We call them papillary muscles. These papillary muscles are connected to the cusp by fibrous cord. We call them chorda tendini. Now, how do they function? Now, you have blood coming from the atria. Atria will be filled with blood and they contract. So, with pressure, the cusp will open, right? So, blood will go to the ventricles like this. Ventricles are here, atria here. Pressure, cusps will open. Now the ventricles will start will be filled with blood. And you have the cusp like that. So blood, cusp will go up and they will be like a tint. If you don't do anything, what's going to happen to the cusps? They're going to go like this, will be everted. Then you don't have a valve, right? This will not prevent blood from going back. So when they become tinted like this, the papillary muscles will contract. When they contract, they bring the cusps together. So they don't do that. Okay? So this is the function of papillary muscle and the chorda tendini. So blood will start filling the ventricles, so the cusp will become like a tint. What's going to prevent eversion? It was in your TBL. Main function is to prevent eversion, not inversion. Eversion of the valve are the contraction or is the contraction of papillary muscles, and chorda tendini will bring the cusps together. What about, so on the left side we have 2 cusps, bicuspid valve, and they're going to look something like that, okay? Well, we'll discuss that later. Now this can be a pulmonary or aortic semilunar valve. Why do we call it semilunar valve? Because it looks semilunar. And whether this is pulmonary or aortic, it's going to have the same design, 3 cusps, 3 semilunar cusps. I know this is aortic from these 2 openings. These 2 openings are the origin of coronary arteries, the arteries that will supply the heart itself. Okay, but you will have a cusp, semilunar cusp. Behind it there is a sinus like a pocket. And here in the middle there is a weight to help it open and close. It's called the nodule. Okay, so this is pulmonary or aortic 3 semilunar valve. How do they function? Do we have papillary muscles and chorda tendini attached to them? No. How do they function? So, ventricle is here. When they contract, they're gonna push the cusp to the wall. Simple. So the cusp is like that. Blood will come from down below. It's gonna stick to the wall. No muscles, nothing. So how do they close?
They will be filled by the blood when it's going.
Now, when you contract the ventricles, okay, and then at the end, ventricles will start expanding, right? So this will create negative pressure. So it's going to suck the blood back. So blood will try to come back, and when it comes back, it's going to fill these sinuses. Okay, so they are like this, and blood is going to come back, it's going to fill the sinuses. So the flaps or the cusp will close. Simple, no papillary muscles and no chordal tendini. Clear? Okay, so pulmonary or aortic, three cusps, semilunar, sinuses behind. I know this is aortic because from behind the right and the left cusps, we have the origins of the two coronary arteries. Otherwise, they look very similar. Okay? Now, this is with the valves. Now, if you were to insert the valves in the myocardium, which is a muscle, that is always contracting, relaxing, what's going to happen to the valves? They will be damaged, right? So instead, the valves are not inserted into the muscle. We have a dense or a network of connective tissue within the myocardium that will provide attachments of the bases of the valves. So the bases of the valves are attached to what we call the cardiac skeleton. Cardiac skeleton, these are connective tissue fibers within the myocardium. They provide attachment and bases of the valves. So the valves are attached to something that is fixed, does not contract. It's called the cardiac skeleton. And the only difference between pulmonary and aortic valve is the orientation of the cusps. In case of the pulmonary, we have right and left and anterior cusp, and the aortic right and left and posterior cusp. Tricuspid valves, we have anterior, posterior, and septal, while the bicuspid valve, we have anterior and posterior only. Now let's open the right atrium and see what we're going to find in there. Once you open the right atrium, first thing you notice that the anterior wall is rough, is not as smooth as the rest of interatrial wall, the atrium, the wall between the atria. Because of this muscle that's called the pectinate muscle. Now the transition, if I were to close this, the transition between the rough and the smooth is called the crista terminalis. And Dr. Zafar, he gave you a histology lecture, right? He said you find the SA node, the pacemaker of the heart, at the upper end of crista terminalis, just below the opening of the superior vena cava. Okay? So the transition between the pectinate muscle and the smooth wall is the crista terminalis. What else? And this is the little extension of the atrium. It's called the auricle. Again, it's rough from the inside. Otherwise, the rest is smooth. What else you see in there? We see this. What is this? What is fossa ovalis? Why do you need opening between the two atria?
During the embryonic
During embryonic life, what will happen? Remember, during embryonic life, we have pulmonary, we have the umbilical vein bringing everything that the baby needs through the placenta from the mother, right? So no need for the blood to go to the liver, no need for the blood to go to the lungs because it's already oxygenated and the nutrients are already processed. So we'll have 3 detours, right? One of them we studied in GI. So instead of the umbilical vein going to the portal vein in the liver, there's a detour, rectus venosus, right? That will take most of the blood to the inferior vena cava. Then the inferior vena cava will enter the right atrium, and instead of going through the normal route, right atrium, right ventricle, pulmonary, lungs, and coming back, why? there is no need because blood is oxygenated already. So 75% of the blood will be going from the right atrium to the left atrium through the foramen ovale. So that is the second detour. The third one, 25% of the blood will go through the normal route, right atrium, right ventricle, pulmonary trunk. Then while in the pulmonary trunk again, it's going to think, why am I going to the lungs? No need. So there will be a connection between the pulmonary trunk and the arch of the aorta, diverting blood from the pulmonary to the aorta. It's called ductus arteriosus. What's going to happen to these structures now? Ductus venosus becomes ligamentum venosum in the liver. Foramen ovale will close, and ductus arteriosus will become ligamentum arteriosum. And you're going to see that in the lab. Have you seen it or not? Are you going to enjoy seeing that? It's a little connection between the trunk, the pulmonary trunk, and the arch of the aorta. It's like a ligament. And they're going to, explain to you how the vagus nerve is descending down the left one. And then after crossing the arch of the aorta, it's going to remember, I have to supply the larynx. So it's going to give us recurrent laryngeal nerve. The left recurrent laryngeal nerve